Well, welcome everyone. This is a new venture in the COVID era. My name is Paddy Coughlin, one of the members of the Education Committee at the Vascular Society, and this is our first attempt at delivering a webinar to try and facilitate some of the educational needs that have been missing for trainees during the last few weeks and likely in the months to come. The other thing to say is this is a first really where the Vascular Society have sort of combined efforts with the BSET Education Committee, the BSET Society. And on that note, this is going to be a BSET-led session, and we're delighted to welcome Patrick Chong from Frimley, who is the chair of the Education Committee at BSET, Paul Moxey, who is also a BSET committee member, and Mike Dialinas from Guy's and St Thomas's. And between them, they're going to try and educate you about the diabetic foot attack. Over to you, Patrick.
Thanks, Paddy. It's a real honor to be invited to kick off the series, and I'm going to start sharing my slides now without further ado. And I want you to confirm whether you can see the slides. Can you see the slides now, team?
Yeah, we can.
Yeah, great. So we're going to be talking about managing the diabetic foot attack, and I think it's an important topic for all of us because these patients form a large volume of the throughput of any vascular unit. And we find that it's often quite poorly taught at undergraduate level. And even some of the trainees coming through the unit as well seem to be unfamiliar with how best to manage this very common and troublesome condition. So those are my disclosures. And the other bits of the webinar will be Paul talking about special considerations during COVID-19, and hopefully we'll be able to take part in a case-based discussion with Mike as well at the end of this webinar. So diabetic foot complications are an unhappy sort of result of a trio of problems. And these sort of pathological processes include a neuropathy, whereby the patient loses sensation of their lower extremities, and also an immunopathy, whereby they lose the ability to fight infection in the normal sense. And also an arteriopathy, whereby there is peripheral arterial disease. And when all these elements combine together, they produce tissue loss in the patient, which, if unchecked and untreated, leads to limb loss. The word diabetic foot attack is really coined by the group at King's College in London. And this is a very good paper written by Prash Vaz, stating the care of the severely infected diabetic foot with rapidly spreading necrosis. And usually these patients have neuropathy, but also ischemia. And it's highly important to treat infection in an expeditious manner, followed by correction of the ischemia. And of course, there are special categories whereby the diabetic foot attack presents mainly with ischemia without tissue loss, and sometimes as an acute Charcot's foot. And we know that the Urodal study published in 2008 shows that without a doubt, when there is infection and peripheral arterial disease, the likelihood of non-healing and also of limb loss is much higher. So outcomes are worse when patients have peripheral arterial disease and infection. And so how common is infection and ischemia in diabetic feet patients with tissue loss? If you look at the data coming out of the National Diabetic Foot Audit and looking at patients with a high SINBAD score, 43% of these patients had infection, and 35% of these patients had significant ischemia. So very common problem. And just as an outline, the principles of treating the diabetic foot are to look out for infection and look out for ischemia and also for neuropathy and deformity. And I will go through each of these in a little bit more detail with the following slides, but essentially we're looking out for temperature differences, cellulitis, collections that need urgent drainage and debridement, raised inflammatory markers, and also bony changes on X-rays, MRI scan, and bone scans for infection. And of course, ischemia, the recording of pulses, ABPIs and their limitations. I'll talk a little bit about transcutaneous oximetry and how useful they have become in our clinic, non-invasive imaging and diagnostic angiography, and also contrast angiography in our patients who are diabetic, because they usually have renal impairment as well. And also looking out for neuropathy and deformity of the foot. I'd like to talk about some of the classifications of the diabetic foot because it's important to know how to describe the condition to our colleagues, and it's important to actually give our colleagues in primary care a system to actually describe these patients to us. Initially, in our unit, we use the Texas classification, and it does talk about the severity of the ulcer in terms of the depth of the ulcer, and also whether there's presence of ischemia or infection, but it doesn't address neuropathy. So we've largely abandoned that, but the GP still like using it for their referrals. The SINBAD score everyone needs to be aware of because it's the one that's used by the National Diabetic Foot Audit. And it talks about where the site of the tissue loss is, whether it's forefoot, midfoot, or hindfoot. It talks about ischemia, although that's just described in terms of whether pulses are present or absent, so not degrees of ischemia. It talks about neuropathy, infection, whether it's present or absent, but it doesn't talk about the severity of infection. And there's also limited differentiation of the depth of tissue loss. And the one that I'd like to recommend to everyone really is the Wi-Fi classification system that's published by Joe Mills back in 2014 in the Journal of Vascular Surgery. And if you're involved in diabetic foot research, you really should be using the Wi-Fi classification. And it describes the patient's diabetic foot problem in terms of the wound depth, the severity of ischemia, and a wound infection. And if you look at the boxes in red, and these are the ones with severe ischemia and also severe infection and very deep wounds. And these are high-risk patients, and they really need to be treated, investigated in an expeditious manner because the risk of limb loss and amputation is high at 1 year. So the approach to treating the diabetic foot in the UK, largely in most vascular units, is a multidisciplinary one. And in our units, we have an orthopedic surgeon, a diabetologist, a vascular surgeon, a tissue viability nurse, podiatrist, and also a microbiologist. And this approach has been well written up by Mike Edmonds, one of the pioneers of diabetic foot care in the UK. So who should treat this problem? It's a nasty problem. This young patient with type 2 diabetes, very poorly controlled, diabetic control with an HbA1c of over 100, with a short history of pain, redness, and swelling, is now unable to walk. The patient's got pulses, is neuropathic, and there's obviously a large collection in the midfoot. Texas 3B, SINBAD, score 4 and a Wi-Fi score stage 4. And so this is a foot attack. So in some units, vascular surgeons will take all these patients, but in our units, there is a triage system, and because the patient's got pulses, the orthopedic surgeons would admit and drain these patients on the same sort of night. Usually, we try and avoid sitting on these patients because the tissue loss, deterioration, and infection can progress quite rapidly. And if you leave these patients overnight, they very often have huge areas that are debrided, leaving feet that are non-functional, and very often resulting in patients needing a major amputation. So the various societies have come up with joint specialty recommendations. These are published in April 2016. And they recommend that when there's an acute foot infection with no surgical drainage needed, perhaps the on-call medical team can take the patient for intravenous antibiotics. And if there's a foot infection needing surgical drainage with no pulses, the vascular team does the job. And if there's an acute foot problem with surgical drainage required, but pulses are present, locally agreed protocols, so maybe the general surgeons or the orthopedic surgeons can do the job. But this is quite, this is non-uniform, and certainly I know that places like Leicester, for example, will have vascular surgeons taking all these patients, whereas at Frimley we will have a triage system involving the medical team, the orthopedic team, and the vascular team working together, but this requires close cooperation. And these patients are often seen by the MDT foot team within 24 hours the next day. So emergency management of the foot attack involves surgical debridement. I'd like to point this out. First and foremost, if there's any sepsis, patients need to go to theaters. Do not let the sun set on these sort of acute feet because delays will lead to disaster. And think of the patient, think of the limb, viability of the limb, and think of how to tackle the local tissue loss, the ulcer. So these patients are often very sick, sometimes needing surgical acute dependency units, maybe even the ICU to step in to look after their systemic illness. They need broad spectrum antibiotics started. And we often take them to theaters for emergency debridement immediately. Don't worry about the vascularity of the limb. And if you look at the published evidence, patients who go into theaters late and have their debridements delayed, they often do poorly, and the rates of major amputations are often much higher, much higher. So the burden of foot infection is huge. It causes discomfort to the patient. There are also physical and mental sort of morbidities. There's a huge increase for healthcare provider visits. There are huge wound care costs as well. And there's also the cost of antimicrobial therapy, which may be prolonged for sometimes for weeks, if not for months. Hospitalization as well. These patients stay in for the longest length of stays. And they often require several surgical procedures to not only debride the foot, but also to revascularize the limb. And these patients suffer up to 25% chance of limb loss at 1 year. So I'm not going to dwell too long on this, but this shows you the diabetic foot infection classification. And there is the International Working Group classification, followed by the other column, the Wi-Fi classification. And I would say that if you're going to look at classifying your feet and describing them for research purposes, use the Wi-Fi classification. We prefer sending tissue or bone samples, and really superficial wound swabs are often useless. And as a second choice, if you can't send tissue or bone samples, deep wound swabs are preferable. And also look out for osteomyelitis, and quite a tricky diagnosis because patients may have normal inflammatory markers, x-rays, but sometimes may probe to bone, and the probe to bone test is a good test. And in 90% of the time, if you probe to bone, the patient's likely to have osteomyelitis. And if x-rays are normal, consider MRI scanning these patients. So these are some of the investigations that we use for osteomyelitis. You can see x-rays. If they're normal, repeat them in 2 weeks if the suspicion is high for osteomyelitis. MRI scans are often very useful. You can see the same patient here. The first metatarsophalangeal joint, there is bone marrow edema, and there's a brightness of the MTPJ, and it lights up also in the radiolabeled white cell scan. Antibiotics, I'd like to say that most units will now have antibiotic regimes that are tailored according to the common pathogens and patterns of resistance for their local population. And these are often outlined in the micro guide, which you should have as an app on your mobile phone. And you should make sure as a clinician that primary care and secondary care refer to the same antimicrobial guides so that they're streamlined. And we do not give antibiotics for prevention of foot infections. So a brief look at the antimicrobial guide for Frimley, and not going into details again. We have categories for mild infections, moderate and severe infections, a special category for osteomyelitis. These patients often require antibiotics for 6 weeks to 3 months. And there are also categories for patients with allergies to penicillin as well. I'm going to talk about ischemia now and tackling ischemia. And transcutaneous oximetry has really come to the fore for our unit. We prefer it to measuring toe pressures. I know some units use toe pressures instead. And there's a very good correlation between wound healing and TCO2 levels. And if you look at patients with a TCO2 level of 30 millimeters of mercury or greater, the wound healing rates are 70% to 80%. And so if you look at the measurements of TCPO2 levels, they can be more accurate than the palpation of a pulse at predicting wound healing. And so how do we make a decision with regards to diabetic foot revascularization? I'm not going to go into too many details because Keith Jones will be talking more on this next Monday, but essentially we are guided by the diabetic foot MDT and the vascular MDT. So patients are discussed and we put patients into our trials as well, both the Basel 2 and Basel 3 trials. But when deciding between bypass surgery and endovascular surgery, really the bypass patients are the fitter, perhaps younger patients, less comorbid patients. They have perhaps more extensive multi-level peripheral arterial disease, which may be difficult to treat endovascularly. They should have a good venous conduit. And it really depends on the team as well on call during the week. And of course, patient choice. And we basically we reserve the endovascular options for the patients that are less fit with more confined peripheral arterial disease and patients who perhaps don't have a good conduit, quality conduit. I'm sure that Keith will talk a little bit more about the GLASS classification as well in his talk next week. So how quickly should revascularization be done? I believe that most of us are perhaps not doing it as quick as we should. I really applaud the Val's unit in Leicester. Rob Davies and his unit came to speak at our Tri-Counties sort of diabetic foot symposium and showed some pretty impressive data. But essentially, the joint special recommendations in 2016 say that patients should be assessed within 24 hours. They should be imaged within 48 hours. And if local endovascular revascularization is planned, it should be completed within 8 days. And if we are honest with ourselves, most of our units are perhaps not meeting these targets. And the International Working Group for the Diabetic Foot says that these sort of patients should be revascularized within 6 weeks, if possible. So I think that's perhaps a bit too long to wait as well. So time is tissue. I'd like to reiterate that. So the quicker you revascularize these patients, they have better mortality, less major amputation at 6 months, and they have better wound healing at 6 months. And the evidence is well documented out there. And this is just one patient from Sataki in 2013, but there are lots of other papers that support this finding. So when should primary amputation be considered? It should be considered when there is wet gangrene.
I've lost you.
Require their legs to pivot, even if they're in a wheelchair, but bedridden patients, perhaps the functionally useless limb, the dead leg, and think hard about how you can do perhaps foot-sparing amputations. If you're doing a major amputation, consider below-knee amputation wherever possible. And again, I'm not going to dwell too much about amputation techniques because there will be a separate talk in this excellent series from someone else on amputation techniques. So non-healing ulcers, what do you do with the non-healing ulcers? And we are all plagued by this problem as well. And we think that sometimes 50% of these ulcers may fail to heal over 4 weeks. So these are the stubborn ulcers. Well, consider perhaps tackling biofilm. And these are slime cities that build on top of the ulcers that may actually hinder wound healing. So debride the wound. And I have only anecdotal evidence from colleagues saying that if they debride the wound regularly, they see quicker rates of wound healing. So think about restarting the whole investigation cycle again, perhaps looking at underlying residual osteomyelitis, looking at perhaps ongoing ischemia, maybe a recurrence of or failure of the angioplasty or stenting or bypass, and also aggressively offload your patients. Some experimental work, including microbiome sequencing, where they use sort of DNA methods to thumbprint infections in the stubborn diabetic foot ulcers, have been started in Glasgow and Nottingham. And they found that the culprits are usually enterobacteria or strict anaerobes in these non-healing ulcers, but these are experimental techniques and really not in widespread use. So just to dwell a little bit on wound care advances, how do you look after these wounds post-debridement? We also have a plastics team that comes around once a week on the ward rounds with us. Negative pressure wound therapy is used extensively at Frimley, and we put these patients for up to 6 weeks on VAC dressings. We also used a VersaJet as well to debride the ulcers. But the VersaJet system is an aerosol generating sort of technique. And so during the COVID-19 season, we have largely stopped using it. Don't miss the red hot swollen foot, because sometimes, this can be missed. and be misdiagnosed as cellulitis instead and sent away with antibiotics. And this is a Charcot's foot. And you should, yes, start antibiotics, but consider immobilization as well with a total contact cast or an air cast walker, and get a diabetic orthopedic foot and ankle review within 48 hours. So if you miss this diagnosis, it can be devastating for the patients. So some lessons from the National Diabetic Foot Ulcer Audits. Get your colleagues in primary care and in the community to refer early, to review their patients early and to refer early. And you can see those who are self-referred or referred very early have much better wound healing rates at 24 weeks and at 12 weeks. And that means that the pathways for referral into your unit must be robust. And whether it's either through a hot foot phone or some sort of email system that you have, colleagues in the community need to be able to avail our services quickly. So delays are the major cause of amputations. And when we looked at our own data presented back in 2013, some of the patients who suffered major amputations waited for up to 17 weeks before they were seen by the diabetic foot MDT team. And a third of these patients did not even have an MDT clinic review before their major amputations. So, you know, delays, try and cut out the delays to these patients. So what happens after a foot attack? So if you look at the patients who are alive, who have no major amputation at discharge, who have no readmissions at 12 months, and with complete wound healing at 12 months, the ideal outcome is only achieved in about a fifth of these patients, and only half of these patients will be alive, amputation-free and ulcer-free at 12 months. So, you know, it's a real problem, and it's like a revolving door. Patients come back. Don't forget offloading as well. So when the patient's healed up, you know, make sure that you pay attention to their offloading in the community, because you can heal them and the recurrence rates are 2/3 if offloading is not looked after properly post-discharge. And these patients are high-risk patients, and they're not really discharged back into the community because their recurrence rates will be high if you do not survey them. So we discharge them to lifelong surveillance in podiatry. And you need to teach patients to present themselves to their GPs or to their podiatrists early. So in summary, you need prompt diagnosis. You need to prioritize surgery for sepsis. Decide on the best microbiology strategy. You need to revascularize early because time is tissue. And also choose the appropriate wound care regime. And also rethink your strategy when it comes to slow healers in the clinic post revascularization and post debridement. So thank you. Try and join us next year at BSET. Sorry, there's no conference this summer. And also try and join us next year at the Tri-Counties Diabetic Foot Symposium. Thank you.
Thank you very much for that, Patrick. That was a very comprehensive review of diabetic foot issues. And while Paul is getting himself set up, there was just there's a couple of questions that have come through, Patrick. I'll just, one of them was a question relating to the probe to bone test. Could you just explain that in a bit more detail?
The probe to bone test is really a bedside, a clinic test that anyone can do. You know, our juniors can, vascular nurses, and also the tissue viability nurses. So essentially, it's an aluminium probe or metallic probe, and if you probe the wound, and if you can hit bone, and you can feel that gritty feeling, that's probably the patient's probably 90% got a 90% chance of having underlying osteomyelitis. Simple.
Okay. So it is with great pleasure that I now introduce a good friend of mine, Paul Moxey from St George's, to give us his take on what we do with diabetic feet in the current COVID climate.
Thank you very much, Paddy. Hopefully everyone can hear me. So unfortunately, unlike Patrick, who's got 100 years worth of published data and papers and guidelines and everything to look at, I've got about 6 weeks. So here we go. So I'll just start with disclosures. So I do receive honoraria from Cook. So I'm going to just have a quick mention on the impact of COVID-19 on the diabetic foot practice. I'll then try and take you on a whistle-stop tour around what I could glean from the internet and from Twitter and from all the various places that we're getting our information from at the moment. I'll then take you through the changes or the lack of changes that have happened to our practice at St George's and at Kingston's foot clinics. And then no talk at the moment will be complete without a quick mention about COVID toes. I think the thing that struck me the most from the outset of this is the harm that that COVID is having on everybody else. We know the harm it's causing the patients that actually catch COVID, but it's the harm that it's causing the rest of our patients. And this patient springs to mind immediately, and as a patient who, in my opinion, has been harmed coincidentally by COVID. So he's a 70-year-old gentleman that was admitted right at the beginning of the COVID crisis, just with his little toe, with dry necrosis of his little toe. And he was seen on a medical ward round, and I think there was a good degree of urgency to get him out of hospital, and he was sent home with follow-up in diabetic foot clinic as the plan, which just that wouldn't be our normal process. And he's obviously come back 6 weeks later with the foot having progressed. And the reason for that is fairly obvious. When you look at his angiogram, he really had very little going into the foot, a sort of isolated segment of anterior tibial, which we did then manage to reopen, but you can see that there's really not very much going on in his foot. So whether he heals this or not will be open to, we'll have to see. But in my opinion, this is the first one of our first sort of casualties of COVID, incidentally. If we look at the effect it's having on clinical practice, I think hopefully most of you are aware of VERN, the Vascular Research Network, and the COVA study that's up and running at the moment. And this was put out on Twitter yesterday by that group, just showing really they split it up into sort of fortnightly aliquots, and initially the first couple of weeks didn't really seem to be much change in people's practice, but you can see the second fortnight and the third fortnight, people moving towards a more conservative approach, and really concentrating on the Rutherford 4, 5 and 6 patients, which is certainly, I mean, that's understandable. As this goes on and as more people join this, we'll begin to get more information from around the world as to how people's practice is changing. So I suppose the first thing to think of is where to look for guidance. This first document that I'm going to show you comes from something called London Clinical Networks, and forms part of a series of information around diabetes and diabetes care. It's written as a risk assessment, goes through and really focuses on the nitty gritty, so workforce, PPE, aerosol generating procedures, etc. And as a good, it's only a couple of pages long, and as a good start point to begin to get you thinking about the real sort of day-to-day ins and outs of how to run your foot service in the current climate. If we're then looking for slightly bigger, I mean, the International Working Group on the Diabetic Foot produced some really comprehensive guidelines, and these things normally take huge groups of people from around the world a long time to come up with, but they've put out quite a pragmatic set of guidance on their website. It's actually quite an interesting interactive website. Clinicians and patients can submit questions which are then answered by members of the working group from around the world, and it changes on a fairly regular basis. But their sort of headline message really is that most patients with a diabetic foot ulcer or condition don't need to be hospitalized. Triage as soon as you can really is, in other words, it's saying keep your clinics open, and I'll come to that shortly. And consider alternative services. And again, I think we're all seeing this, but this is trying to get your clinic set up away from the hospital if you can. That's not always possible, of course. Telemedicine, virtual clinics, etc. We move on to this paper, which, if you don't know David Armstrong, he's a prolific writer, tweeter, blogger about the diabetic foot. He's quite a character. He's quite an interesting character, and it's worth just having a read of this. And he turned his unit first in Phoenix and now in Los Angeles into really a world leader when it comes to the diabetic foot. And they've put out this publication, and they're one of the first groups to really try and split things up to stratify these diabetic foot patients into various groups. You've got essentially trying to keep them out of hospital, which is what we're all trying to do, isn't it? But then you've got the critical and the serious group at the top, and then a guarded and a stable group towards the bottom. And you can see we're talking about telemedicine and home telemedicine and podiatrist offices, and really only that critical group, which is a small percentage, and only 0.25% of patients with diabetes will be in that critical group that actually need to be hospitalized. And they're obviously the ones with gangrene and sepsis and acute limb-threatening ischemia. The Australians have done something similar, produced a similar stratification of these patients, and again talking about some telemedicine, home visits, and about trying to identify who's stable and who's that critical group. I thought I'd put this in here, partly because it illustrates an interesting phenomenon that's taken place in the last 6 weeks, which is that the landscape of medical publishing and peer review seems to have gone out the window. You can, if you put the word COVID-19 into an abstract, I think it gets accepted at the moment. But what I think what this, admittedly, this is an editorial. And it raises some interesting points. To the best of my knowledge, there's no data yet that would suggest that diabetic foot patients are any more susceptible to the effects of COVID-19 than the other comorbid patients. But of course, it's early days, and we'll wait to see. There's an interesting thought in this paper, sort of two polar opposites, really. One, that the way diabetes affects your cytokine response levels may relate to diabetic foot patients having poorer outcomes. But also on the flip side, suggesting that possibly the poor mobility associated with diabetic foot ulcers may confer some sort of benefit when it comes to socially isolating yourself. And again, we won't know the answer to these questions, but this is the type of of paper that we're reading. And I think what it means is that you have to really go into anything that you're reading when it comes to COVID-19 with an open mind. There's really very little data and a lot of theory, which there's nothing wrong with, but you need to obviously bear in mind when you're reading this stuff. As ever, a word on caution. You might think that we've only, in the last 6 weeks, been talking about using mobile phones and remote messaging services and teleconferencing to assess people, but this paper, published back in 2017, suggested caution when it comes to using mobile phone images in your clinical practice in isolation. And actually, we have some experience of that. We performed 2 toe amputations on patients at St George's who were then sent back out to the community and were followed up in a diabetic foot clinic in a spoke hospital. And the podiatrist there took photographs of them and sent them back to the on-call consultant. And the way the pictures came across on the iPhone really made it look as if the wounds were dusky and ischemic and possibly necrotic around the edges, prompting both patients to be sent back up to St George's. But actually, when you saw them in the flesh, the wounds just were a bit fluffy, but they were pink and healthy, and they just needed topical debridement, and both patients were sent home again. So we've got our own experience of it. I think it's just a word of caution that, of course, we want to move towards using this type of technology, and it can only be a good thing, and I'm sure it's going to be the future, but it needs to be done with caution. So how have our services changed? Well, I was Googling pictures of Thomas Addison unit at St George's to show you. I found must be a photograph taken at least 20 years ago of Mr. Jones, looking very young. But as you can see in the bottom picture, the Thomas Addison unit, the diabetic foot unit at St George's, has its own access from directly from outside the hospital. So the patients don't have to troop through the hospital, which is a bonus. How have our services changed? Well, to be honest, both at St George's and at Kingston, we've changed our opening times or the referral criteria. It's still a very open door, and we've not reduced the number of patients that we're able to see. But we have seen a corresponding decrease in foot as patients choose to stay away from hospital. The diabetic foot clinic and the vascular hot clinic services are both considered essential services, and they've kept running the entire time. We've not reduced them, as I say, and we've encouraged patients wherever possible to come into the hospital to be seen. Leaflets have been sent out to our foot protection teams in the community, explaining that the service is still open and how patients can get in touch with us. We have a psychologist as part of our multidisciplinary foot round, and she's been performing telephone consultations. We're not currently using video consultations with our patients. I'd be interested to know if anybody is. And that's really because of a lack of a suitable platform to do that on, and the fact that the vast majority of our patients wouldn't know one end of Zoom from the other, as neither did I till a few weeks ago. But we are doing our MDT meetings via Microsoft Teams and Pando, and the more we do it, the better we get at it. I've taken this from actually slides published on the working group for the International Working Group for the Diabetic Foot, but it's from King's, and they've really thought to split their PPE into 2 categories: a high risk and a low risk set. The main thing being the face protection and an FFP3 respirator mask. Patrick mentioned this earlier, but using things like VersaJet and ultrasonic debridement is really not possible at the moment because of the potential for it generating errors. VersaJet, if you've ever used it, makes a right mess at the best of times, and it's not really the right thing to be doing at the moment. In terms of casts, I mean, there was some advice not to use total contact casts at all, partly because of a feeling that patients wouldn't be able to come into hospital as often as they would need to have the wounds reviewed, but also that in order to take them on and off, you obviously require an electric saw, which may be aerial generating. We still continue to use casts, contact casts, because we do find them, they're incredibly useful, but we're splitting them so that you put the cast on and then you split it and then tape it up, so that the cast can be removed easily and for an inspection of the underlying wound, and then put back on again without the use of a power saw. And then for more general, sort of more low risk procedures, we've again adopted a similar technique to King's, which is not an FFP3 mask, bare arms this time, and it's trying to limit the amount of interaction time with patients. And just finally, you may have heard about this condition called COVID toes. And so I put it on here. Whether it's directly related to diabetes or not, again, will remain to be seen. It doesn't appear so from what little literature there is out there, most of it being case reports. Essentially, it seems to be unrelated to the sort of vasopressor, sepsis, vasoconstrictor, necrosis that you see with very sick patients, and instead it resembles more of a chilblain or a frostbite-like rash, seen often in children and young adults. I couldn't find any direct evidence that it actually leads to digit loss or sepsis, and more is just a painful, concerning condition that is a sort of one of these more unusual manifestations of COVID. But it's something to be aware of, because obviously if you're doing foot clinics and you're being asked to go and review people with unusual lesions on their feet, then this is something that is important to be aware of. That is it from me, but I'm very happy to take any questions or comments that you have. And in particular, I'm interested in, and if people want to contact me offline, I'm interested in whether, in how other people are running their foot services, and whether you've got any other ideas for how to manage things at this particular time.
Thanks a lot for that, Paul. That was very, very interesting and very pertinent to the problems that we're facing currently. So our final speaker for the evening is Mike, who's going to give us a case, to run through a case. While he's getting set up, there are a number of questions that we've seen. Some have been answered, but I think once we've gone through this case and Mike's taken us through this case, we might come back to one or two of the questions for some of the panel to sort of elaborate on. Mike, over to you. Thanks.
Hi, good evening, everybody. So I'm going to start presenting a case, but I'm going to start not sending the pictures, but show you the letter from GP. Normally, the vast majority of cases do come by any, but there's a good number of cases that come fairly neglected from GPs or from nurses, podiatrists, or for whatever source you think is appropriate. So this is a typical letter we receive for a 75-year-old male with 2 months history of a blue toe. He has ischemic heart disease, a previous cabbage, and he has type 2 diabetes, and he's a smoker. So the question is obviously what do you do with this letter? How much value do you put to the description of the blue toe? Is it something you can ignore and leave it to, say, at the bottom of the pile to be seen as regular, or give him an urgent appointment? Now, for these cases, has been from previous experience again. Now, what we tend to do, we tend to phone GPs and get more information, perhaps a picture of the toe or whatever they are concerned, to help us prioritize the blood work. So I've decided, based on after spoke to the GP, to bring the patient the next week, see him, and hang on, and that's what I got. So that was the blue toe as described. He's been there for approximately 2 to 3 months. He's been managed conservatively by the nurse, and the GP just simply saw it a week before he referred it to us. They thought they were not getting anywhere with topical management, and they thought perhaps it's a good idea to send it somewhere else. I'll give you some different pictures of this. The patient himself was not in a bad shape. He had no temperature, no other problems as such, and the GP was fairly reassured by the fact that This is obviously a total that doesn't look right, but the patient has no temperature, and he actually done a white cell count, was more or less normal at 7.6, which puzzled the GP, but not us. So the first impressions, how would you think about this? I think this patient should come to ideally a diabetic foot clinic. There you have the optimal setup, as Patrick suggested. You do have a diabetologist, you do have a vascular surgeon, you have a vascular specialist, we have a clinical psychologist as well, and a specialist podiatrist, and also an orthopedic surgeon. It's quite important to understand that diabetic foot management is not actually a surgical problem. It's an overall medical management throughout their lives. And just by doing surgery, you never cure the patient. You do need, the most important thing is how to proceed after you finish your surgery. So for him, as you can see, it was fairly skimming. The patient was fairly well. There was a red. There was perhaps a bit of pus coming out if he squeezed it. He has no sensation. And what we decided to do, obviously, we admitted the patient. Transferred him. He was seen in my outreach clinic. He was transferred to St. Thomas's the following day as an urgent admission. And on these cases, if the situation is such as this, and has no pulse, that this one didn't, we decided to go straight for a CT scan. I can't show you a CT scan, but what it shows a very small lesion in his right internal iliac, approximately 6% stenosis, and SFA occlusion at the level of the mid-thigh with reconstruction again, the adductor canal, and some distal disease as well. So what we decided to do after we take all the history, examined him, investigated him, is first thing is to do an iliac angioplasty. So we took him to the theatre, did an iliac angioplasty, and again assessed how much flow he got down his foot. Again, that wasn't enough. And the next step was to attack his SFA. Now, you may see it's not very clear from the CT, and sometimes CTs are deceptive. That's why if you're not particularly sure about what you see, it's best if you evaluate it either with a duplex to see if there is any significant stenosis, or if you decide to go to do an angiography, you can either measure pressures or see it from different angles. So that was plastered, then the stent was put, then it was a downstream angiogram. As you can see, you have this more or less multi-level small disease, but not significant problem at his profunda and his SFA. This is only a picture, but there were multiple angles to evaluate mostly the profunda, which is quite an important vessel for this patient. Going down, as you can see, there is a very well collateralized lesion with an SFA occlusion. And at the time, we discussed it, and we thought the best option is to, rather than stent, try and angioplasty it first and see what we get. Below that, you can see just the outline of the major vessels. There wasn't any specific occlusion as such, but it was multi-level disease, enough to tip the balance to make him in the position you've seen. So, and that's the foot. It's quite important whenever you do angiograms on anybody with diabetic disease to look actually at the foot itself. As you probably do know, the diabetic feet, diabetic people do have quite a lot of disease in the infragenicular vessels, but somehow the foot vessels seem to be spared. That's why all the people bypass seem to be quite successful. There's a very good series from King's that has demonstrated that very successfully. So it does have, as you can see, people. There was a bit of a peroneal, but again, nothing much. It was definitely was an incomplete arch. So we proceeded to balloon angioplasty with a relatively decent result. There was a bit of dissection, but the flow was pretty rapid. And down in the foot, you can see immediately that the flow was significantly better. You can see better the vessels. There was still some disease in the DP trunk distally, but everything improved significantly. Then we decided, as he had two-level disease. Now, this was done in hybrid theatre, and at the same time, we'd taken his toe off. Now, the important bits with these is, I found from experience, is whenever you do amputations of similar cases, is either you do too little or sometimes you do too much. I think it's quite important to take away all the tissue. And yes, you can go and experiment with X-rays, with MRIs, and they will show you there's osteomyelitis, because they all have osteomyelitis, the bone, as Patrick said earlier on. But it's a quite a good test when you take the bone out to feel the area. Any bone which is really friable, it really should be taken out, and you should go down to really good, proper, well-vascularized tissue. I've introduced loops in when doing debridements nowadays, because I think it's quite important to see properly, and it has made a difference. And I take a lot of time when I do debridements and take toes off, and I just don't simply take it out and leave some sort of bleeding tissue and go. I take a lot of time to debride every single pocket of pus and clean every single dead tissue out. And again, if I see the second toe, adjacent toe, to be affected, I'll have no hesitation taking it out. These people have multi-level disease, they have lots of problems, and the last thing you're going to do, multiple returns to theatre, because the only thing you do is just expose them to more anesthetic, more danger, and again, more infection. It's quite important to get also the antibiotics right. They all have multibacterial disease, and have more or less a similar regime than the one that Patrick suggested. And again, we send tissue, we don't rely on swabs. I don't think they're of any value, they're always contaminated with skin flora. The only thing you do is you just get false results. You need deep tissue, ideally bone. You can send the whole toe, you can send bone fragments, anything you like, but provided you do that. The other thing you do is you need a very switched on microbiologist and a team that understands disease as such. People with diabetes do have neuropathy and also have a diminished inflammatory response and reaction. So what you see sometimes is not a true, it doesn't reflect the whole disease. Sometimes you do see that people have a very diminished response to injury, and they do have a mildly red foot and a massive amount of pus underneath. Not something you will expect for anybody else. And that's because they have a reduced axon reflex and then normally produce less serotonin. Therefore, your presentation of the inflammatory response of the body is less pronounced of these people. So don't be afraid to do a good debridement. Take away as much tissue as you possibly think is appropriate to reach, healthy bone and healthy tissue. Again, you need to think again how once you do that, if you how the patient is going to walk afterwards. Try and do an amputation that's going to give you some sort of functional foot. It doesn't matter if it looks ugly, they always look ugly, but there is a lot of evidence nowadays with reconstructive plastic surgery. You can get people to recreate foots and walk on them for a good number of years. Obviously, this all depends upon who you have in front of you. A 50-year-old taxi driver will have a different operation from a 95-year-old who's semi-dying, or which somehow somebody thought it was appropriate for you to treat. So it's quite important to treat not the disease, but the patient itself. It's really, really important to believe in that and actually do it. The patient is about 4 months now. His wound is now healed. I have no recent photograph, but he hasn't turned up for review because of the COVID. But he's doing fairly well after that. He stayed approximately 4 weeks in hospital with a negative pressure dressing and 6 weeks of intravenous antibiotics, followed by another 2 weeks of oral antibiotics at home. Again, it's fairly important once you discharge patients, such as this one, as a typical diabetic patient, to know exactly what setup they're going to. If you don't have the ability to follow them up yourself in a diabetic clinic, or if you rely on a district nurse that will simply change the back and give you some feedback, if they do, about the progress of the wound, you have to be confident they will know exactly what they treat. We did found the last 2 years, especially in my outreach clinic in Darren Valley, that the vast majority of people we treated return back simply because of poor local care. And that's a quite important feature when you set up a vascular unit and when you set up a diabetic foot service. You need to know who these people are going to go to. If the GP doesn't understand this, if it doesn't, please let them know, please educate them with local courses, seminars. And if you're still worried your patient is not in good hands, please bring them back to the diabetic foot clinic. It's quite important.
That's great. Thank you, Mike. Fantastic. That was sort of brought everything together. Now, I think we've got a little bit of time for some questions. There's been a large number of questions that we've had, and quite a lot of those have been answered by our faculty. So thank you very much for those questions. I think one of the themes from the questions was with regard to tissue sampling within theatre. So Mike, have you got given that we were talking about 2 amputations, then have you got a sort of a way that you deal with getting sort of bone and getting the appropriate microbiome?
So we always do superficial deep tissue samples. It's so I would say sometimes the registrars is more or less like doing cancer treatment. You take away whatever you have to take. At the same time, I do biopsies from everywhere, send tissues from everywhere on the tissue on the toe I've left, or on the foot I've left, to make sure these are free from infection. I do very, 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 very thorough wash, and I send samples in different pots, so to avoid contamination. And I'm in contact with the microbiologists, because we have a specific team of microbiologists that deal with diabetic feet, to make sure we get results properly. We start everybody on empiric treatment, and they go on specific treatment once we get the results back. You never get away with 2 weeks. It has to be at least a long term of antibiotics. And I think there's a very good series from Mike Edmonds at King's has shown that if you put them antibiotics for a very, very long time, you can save toes, legs, and feet. Again, I'm not so sure it's replicated all the time, but it's something that we do.
And do you close wounds, or you do usually leave them open?
It depends. I used to close wounds in the past. I've lived to regret it. And I think nowadays, from my experience, I leave most wounds open. If I have a very, very clean wound, and I have a very young patient, really good blood supply, I'm confident, I will close it. But again, the vast majority are left open. We don't normally see the wounds that are easy enough to close. They always get a deep debridement. They always are quite difficult to close, and I will not compromise the wound management like this.
Yeah, sensible. Patrick, question for you. I know you've answered, perhaps, and Keith as well has answered a little bit. It's just with regard to the TCPO2, really. I know probably not a lot of units have it, and just a brief resume of how you use it, the sort of the technical aspects around it might be quite useful.
Yeah, so the transcutaneous oximetry has been in use in our department since perhaps around 2010 or 2011, and we use it on all our new patients coming in with tissue loss. And also we use it to look at the effects of sort of revascularization on patients. And our foot and ankle surgeons will not do any major sort of reconstruction or offloading surgery unless they have a TCO2 level to go by. And we say it's 35 in our units. I know the International Working Group for Diabetic Feet put a cutoff point at 20, which we think is perhaps a bit too low, 20 millimeters of mercury. We go 35 millimeters of mercury, and we usually see pretty good wound healing. And we use it for also ascertaining whether or not the patients are going to heal for major amputations. So we will do an above and below knee level sort of tests in patients that are being considered for amputations. And most of the time, if they've got a TCO2 level above 35, they'll heal below the knee.
And in the foot, we don't use it in cage, but I'm aware it's a dorsal and a plantar probe. Is that right? So which one do you go off for the 35? Because they are different, aren't they?
Yeah. I think that I mean, obviously you'd like to have both your sort of readings over 35 if possible. I think that the foot and ankle surgeons are reluctant to do a transmetatarsal amputation in elective patients if their plantar sort of surface measurements are inadequate. And so you have to look at revascularizing your patients aggressively. And I know that there are lots of people who are tuned in now who will support that as well. And we have to make sure that these patients heal, and they don't sort of come in for foot sparing amputations and then end up having sort of subsequent levels of more proximal amputations because of failure.
And from the point of view of above knee and below knee, where are they probes sort of for the below knee, is that sort of where you do the long posterior flap, or?
We put it mid calf and mid thigh. That's what we say to our tissue viability services.
And I think I think it's probably fair to say that TCPO2 is probably not available in the vast majority of hospitals, I suspect.
Yeah, I think it doesn't cost that much to set up. I think that we got our kit fairly sort of easily, about £4,000, perhaps a bit more now. And I think that with the Wi-Fi classification, you either do toe pressures or you do TCPO2 levels. And I think TCPO2 levels are much easier to actually, much easier to do. And you can train your podiatrists and you can train your tissue viability services to do them.
Can I just chip in? I mean,
Yeah, of course you can.
We've recently acquired a TCPO2 unit that does TCPO2 and toe pressures. It's a lot more expensive than Patrick's £4,000. So maybe
radiometer.
Talk to the supply. We've got the Pyramid one. But the thing for us, what we're learning with it is that it's probably a statement of the obvious, but you've got to put it in context with everything else, and one number means nothing really. It's about learning what that number means in conjunction with the angiogram, in conjunction with the duplex, in conjunction with the patient and their diabetes control, and coming up, and you get a feel for it. There have been a number of publications that have tried to show that one is superior to the other. I think actually toe pressures come out supposedly as a better predictor of outcome. Mm-hmm. But I think these are useful things to have up your sleeve. And I particularly think that using it for above and below knee amputations is an area that there's not a lot of information on, but is actually a very useful, would be a very useful tool and a very useful place.
Super. So the sort of another theme, another question is really with regard to the role of community, how we get patients out of hospital and deal with people in the community. There's a specific question around VAT treatment. And so asking any of the panel really, how have you managed to interact with sort of community teams to get patients out of hospital but still maintain their sort of wound management? Do you want to start, Paul?
Yeah, I mean, we have fantastic community foot protection teams, podiatrists, etc., who really do a great job of linking in with us. What we don't have, and which still remains an enormous frustration to me, is the ability to send patients home with a topical negative pressure on their foot and for it to be managed in the community. There's this ridiculous argument about who's going to pay for it, who owns the pump, etc. We end up with patients spending days in full price hospital beds when they don't need to be. And I think it's one of the sort of the last things that we try and break down, because the networking that's gone on and the networking that's possible, it was possible before COVID, but is even more possible now, should mean that we should be able to get patients in and out of hospital pretty quickly, and then they have their wound management in the community.
Anybody else? Any sort of moving on from that, and I think probably relevant to where we're at the minute is I know that nearly all the panelists work in a hub and spoke arrangement. How have you managed your diabetic foot service in the spokes? Mike, do you want to, as you said, you were out at you did a bit of spoke work as well, like I did. Yeah. How have you managed?
So we at Thomas have a number of spokes around, and I'm one of them. So now I'm started managing the rest of them from next week. Every single one has a diabetic foot clinic, and in every single one, simply because they're on the peripheries and the impact of COVID seems to be less. And we have managed to run in all of them a diabetic foot clinic, which is a face-to-face clinic rather than a video clinic. And we see very selected patients. The process is as follows. We just simply screen every single patient very carefully. We do a lot of telephone calls to GP and patient before we decide who we see. We take all the precautions as appropriate, and we continue to see patients. Now, as regards to the community, because quite a few of them now have to be managed in the community more than we want them to. We have done a number of seminars and teaching days for our local GP practices, district nurses, and podiatrists. So we do know all of them. So they all have been trained to more or less the same level. And every single patient goes back to the community case, goes with a very detailed leaflet of instructions to what to do and how to do, contact numbers, and also an email address that can access and send photographs or concerns if they so wish. We have a very low threshold to review patients in clinic if we think things the community are not doing well. And that's a recent restructure we've done the last few months, simply because we audited our results. And even though you get patients to treat them in the hospital, and once you get out of the controlled environment and they go back in the community, then things tend to slip sometimes. And you see the wound management not being so good as you expect to do. There was a great variation amongst the way that district nurses or GP practices were managing wounds. So there were various lotions and potions placed in, different ways of applying correctly or incorrectly the negative pressure wound management. So we, at the point now, I can say we started more or less standardized the treatment in the community. And it's equally more important now, especially with the COVID. The only problem we've seen is we tend to see more neglected wounds coming back as of probably last week. And we tend to see more neglected patients coming back, and the new referrals we get are fairly delayed, more than we expected to be for that area. And I suspect that's a result of COVID.
Yes, that's probably a similar thing that we're seeing. We're almost up for time. I've got one last question. So anybody who wants to take this from the panel, and oh, it's gone. Who's taken? Maybe it's gone. The role of Integra. Did you just answer that, Patrick?
So I think mixed results at Frimley Integra. These are sort of skin substitutes. We've had some really early failures as well. And I think that, I'm not sure how much they cost, but you need a very clean, well-granulated wound, free of infection, and also, the revascularization needs to be perfect. And we don't really use it now. We've had a series, we had some failures, and so we don't really use it now.
Super. Right. I think we shall call time there. First thing is to thank the panel for their time. I've certainly learned something this evening. I hope everybody that has joined the webinar has done so. I hope those of you who signed in have enjoyed it. I hope that it has been educationally benefit. This is the first in a series of weekly webinars that we're going to run all the way through to the VSASM, if that does occur. So this is a long-term project that between BSET and the Vascular Society, we aim to try and aid in some degree of education. There's going to be a weekly topic, and again, like you've done this week, there'll be a link to sign in with. The details, the link changes every week, and the details for that will follow either from the Twitter account, and the Rouleau are going to send out the details as well. I'm happy to accept emails as well if you're not on Twitter or can't access Rouleau email, website, and that sort of thing. Obviously this is the first time that we've done this. We'd be very grateful for as much feedback as we can possibly get, that we can try and make this better as we move forward. It has been videoed, and we're going to get this onto some to the appropriate websites for people who haven't been able to join this evening to join later on. So finally, thank you to all the faculty, and good night.
Good night. Thank you.
Thank you.